We're going to start on time. I want to welcome everybody to this Heart Cafe on behalf of the World Heart Federation. This very, very important session focused on integrating care across cardiovascular, kidney, and metabolic diseases. First, want to thank the World Heart Federation, Lana Respel, who's been a force behind these Heart Cafes and a lot of the very important work of the World Heart Federation. Want to thank Bayer for their sponsorship. Thank all of you for making time out of the busy Congress to attend the Heart Cafe today, and to our three esteemed panelists here that will be introducing themselves shortly. Just as some brief background, as we think about the word I like to use is interconnectedness. You know, in medicine and public health and in science, we often are siloed, sometimes unintentionally, sometimes just driving what we are focused on, you know, independent goals. But this is a critically important area because this interconnectedness is truly a head-to-toe problem. It is both macrovascular but also microvascular. And as we talk about the concept of epidemics, we should think about syndemics, this interconnectedness not only of disease states that are not happening by chance, but the interconnectedness of disease states across our communities, and especially impacting our communities that are most challenged. Lastly, this area truly is one of the biggest threats globally, and thankfully, World Heart Federation and many other organizations have recognized this as one of the top priorities in medicine, public health, and public policy. I'm Larry Sperling. I'm a professor at Emory University School of Medicine, Atlanta in the US, and I've had the opportunity to work with World Heart Federation now for a decade or more. And I'm also co-chairing a roadmap in development that we're very excited about. It's a roadmap on integrated care in people living with risk for heart disease or heart disease and living with multiple long-term conditions. So very relevant to our discussion today. So now I'm going to hand off to our panelists to introduce themselves. We so appreciate them joining us today for the Heart Cafe. And then after that, we're going to have a conversation. And then we're going to open up, hopefully saving about 15 minutes for the audience, for their questions, their comments, and then we'll conclude on time. So please.
Thanks. I'm Andres Rosende. I'm medical doctor, cardiologist, and since 2021, I've been working as international consultant for the Pan American Health Organization. Pan American Health Organization is the most important public health agency for the region of Americas. Is the regional office of WHO in the Americas. We specifically focus on heart initiative, and I hope I can share with us the highlights of this program. Thanks.
Yes, thank you so much. I'm Tazeen Jafar. I am a nephrologist or a kidney specialist by training and a professor at Duke University Medical School in Singapore and also at Duke University in Durham, North Carolina. My work has been, I'm also a clinical epidemiologist, and I do community trials and build models of care. A lot of them have been in South Asian region, in Bangladesh, Pakistan, and Sri Lanka, and also in Singapore. So a lot of them in the Asian countries. And so most of them have been on cardiovascular prevention. And so I deal a lot with metabolic risk factors and prevention of them. Thank you, and I look forward to discussing this more.
Thank you. So I'm Glaswegian, so you have to change your listening. So I'm Naveed Sattar. I'm from the University of Glasgow. I am a clinical professor in cardiometabolic medicine, which means I do preventative cardiovascular disease and also many years of diabetes. I think over the last 10 years, I've realized the epidemiology is changing much faster than we realized. There's much more obesity-driven disease. There's much more hemodynamic disease, more people living with long-term multiple conditions. And we're a bit behind. We're struggling in many health systems around the world, not only high income, but low income. And we need to find solutions. And I guess that's why we're here, Larry. Yeah.
So let's dive in because, we certainly are very good at describing gaps, barriers, roadblocks, but I like how you frame it's time for solutions, it's time for action, and it is time for impact. So maybe to start out with Professor Jafar, this coexistence we talked about, whether clustering, interconnectedness, CKD, metabolic conditions, cardiovascular disease, on and on and on, MASLD, dementia. We could use the alphabet, honestly. Why is this truly a global epidemic now? Why are we behind the curve? And then why is this urgent?
Yeah, no, first of all, thank you, for hosting this session. This is great and very timely. These conditions we are seeing, should not be using the word epidemic, but really such a rapid escalation of these, the multimorbidity. I think in part, several reasons for this, aging population growth and all that, exposure to risk factors. But I think a lot of the reason why we are seeing is that we've been neglecting the diagnosis and when we've been thinking in silos. So first of all is the underlying pathophysiology. The underlying pathophysiology, there is common, the obesity and the vascular risk factors. There is commonality, but our thinking has, like I said, and you've said in the beginning, has really been thinking of the individual disease conditions. So that I think has been a mistake. Now we are seeing, in all of our studies that we are seeing somebody with hypertension, 30 to 40% of them have diabetes. Up to 40% of adults with hypertension will have kidney disease as well. So it's the prevalence and the burden of multimorbidity is so high that is just it's just not right to be thinking of the single etiologies as well. And a lot of that, like I said, is because of the underlying obesity. And the manifestation of that obesity is not just the BMI, is also the visceral obesity. So underlying and the inflammation. So I think our thinking about this has to evolve, and we have to shift the paradigm of how we think about the multimorbidity. And so the evolution of the CKM approach introduced by the American Heart Association, the presidential advisory of a couple of years ago, I think is absolutely, the move is in the right direction. And it's there for a couple of purposes, and I think we're going to debate that a little bit about. And a lot of it is about how is to create multidisciplinary team approaches for management. So I think we can, also because we have the newer treatments, better therapies now available to treat these individuals and to prevent the progression and adverse outcomes. So I'm going to stop here, and then we'll come back. Thank you.
Yeah, and thanks for mentioning the AHA initiative. I was part of the AHA team that launched the CKMH initiative and also derived and validated the Prevent Risk Calculator. We have leaders from across the world here, and we know that health is local, and some of the solutions likely will need to be local as well. Maybe for our other panelists, why are we seeing, geographic challenges in either specific global regions or local areas? Yeah,
well,
please.
I can build on, I think Tazeen, had a beautiful summary there. In some ways, we are, in a sense, victims of success. We've, reducing people dying from premature cardiovascular disease is a good thing. Reducing people dying from heart failure is a good thing. From kidney disease is a good thing. And, we've had better treatments over time. But they're not perfect by any means. But of course, the fuel of obesity and sedentary lifestyle all over the world is pushing, that's the one risk factor. Obesity and diabetes have been going in the wrong direction substantially. And then you have a classic coming together of people living with more obesity earlier, more diabetes generally earlier, more prevalence, and people living longer with other chronic diseases. And they've got common risk factors that then leads them, so the person who has an MI very much less often dies, will live longer with risk factors, with more obesity, we're more likely to get diabetes, more likely to live to get kidney disease. And the same is happening in heart failure. Patients with heart failure no longer only have a 5-year survival of 95% 5-year survival. It's now 15, 20 years. And then they live longer. We're also stopping cachexia. They're living longer, and guess what? Living longer with more obesity, then they get more kidney disease, get more diabetes. So it's partly success, and we have to admit that, but it's also partly societal failure, and it's not our failure, it's a obesogenic environment. And we mustn't shy away from it. Our food environment is terrible. It's profiteering. I hate to say it, but that's partly what it is. And that then is driving all of our risk factors and fueling them and making them worse. Plus, we've kept people alive a lot longer with therapies which are not perfect. Sorry, Tazeen. So that's partly the problem. And I don't, we're a bit behind the curve.
Yeah, so success, people are living longer, but at the same time, we like to think about the ticking clock hypothesis, which means this is a gene environment behavior interaction, and the genes are very prevalent, predisposing to this CKM multimorbidity situation. At the same time people are living longer, we are starting to see overt disease in younger populations around the world. And so would love to hear about the Hearts in America program, the successes there, but also the lessons learned that we could think about on a global level.
Yeah, thanks. First of all, I agree with my colleagues in this emergent problem, which is the same of I remember in the late 80s, the X plurimetabolic syndrome, which evolved later in just metabolic syndrome, which evolved later into cardio-kidney metabolic syndrome. A couple of months ago, I heard cardio, kidney, liver, metabolic syndrome. And in this Congress, I heard cardio, kidney, liver, inflammatory, metabolic syndrome. But it's the same cluster of interconnected risk factors, and it represents the main public health problem, because people are dying by conditions related to this cardio, kidney, metabolic, and so on syndrome. So I think we urgently need to develop practical and implementable solutions to address this emerging pandemic instead of rebranding it every 5 years, because it doesn't make sense. So Global Hearts Initiative is a flagship program from WHO to address cardiovascular prevention and focusing on primary health care settings where most people are seen every day. Initially, Hearts was born in 2016 as a program primarily focus on hypertension due to high prevalence in adult population. But in the region of America, it has evolved in the last 4 years into a quality improvement program which expand its scope to address other interconnected conditions. So far, Pan American Health Organization, of course, is an international cooperation public health agency, but so we don't implement HEART directly. Countries in the region implement HEART. We provide technical support, we develop capacity building strategy, we publish papers to shape the way in these conditions are addressed. But so far, we have 28 countries actively implementing the model in the region of America, and 9 of them are scale up to more than 80% of primary healthcare centers. And our approach is based on a clinical pathway, which is a practical and straightforward one-page evidence-based instrument to treat and address these patients in a comprehensive manner, avoiding vertical and fragmented approach. So I'm going to stop here, and then we can skip.
So, I often describe, at least in the U.S., our delivery of healthcare as fragmented, episodic, and catastrophic. And so we talked about interconnectedness, the biology that's interconnected, the health conditions that are interconnected. But what I'm hearing is the solutions also are related to interconnectedness. So for Professor Jafar, I know you've done some really impactful work in the primary care setting. And just to emphasize, we need primary care. We need the people themselves, the patients, the communities, public health. It comes back to that interconnectedness. But we'd like to hear about, as far as solutions, what about some of the work you've done and what we can learn from that?
Yeah, thank you for that. So I'll give you examples, a couple of examples of work in lower middle income country settings, and then also some high income country settings if we have some time. So from the low and middle income country settings, I mentioned our work in Bangladesh, Pakistan, Sri Lanka, where we worked when building models of care for, we used hypertension as an example. Care in these settings, unfortunately, as you've just heard from our colleague, is you talk about episodic care in the US. Unfortunately, in many low and middle income countries, they have not even focused anything on the non-communicable disease, not even happen. So they've really been focused thus far on infectious diseases. And so our goal at that time when we were starting these care models was start with the majority condition, which is hypertension, almost like 40% prevalence. And then once you build a program, then you can add on other. So I think we're moving in that direction of the CKM. Hopefully, that's the next step. And so we work with the community health workers, so non-physician healthcare workers going into the community, linking them up with the primary care. So them going. So I think with that, these workers live within the communities, build trust, go with the monitors, do the DASH type of diet with the home health education. And those types of models now have been shown in a lot of different community settings, not just these countries. So in Kenya, in China, in Colombia, Malaysia, a lot of the countries, these types of models which are community-based, link primary health care with the communities, with the community health worker, non-physician healthcare workers have been shown to be successful. And I think those are the models where with the trust building, empathy, social care, and empowering patients. So this is the other element here. So those models have shown a lot of success with hypertension management, and I think with diabetes care as well. So I think the evolution and building on that and building cardiovascular, There are going to be and in Singapore, we worked with, is a very sophisticated, relatively, obviously, setup. We worked with, within the team-based care models there, which are a little bit more multidisciplinary, with motivational conversation with the nurses. So again, team-based care models with multidisciplinary and with digital health integrated within them. So those kinds of models are a little bit more assist the physicians and assist and make it easier. So I'm going to talk a little bit more later about how AI can help, and that's our experience in Singapore. But how they'll go into the low and middle income countries, I think there's going to be a little bit of a challenge there. But we have to think about adaptation and modification and think what we can do and sort of move beyond these silos and adapt. So some of the things that my colleague is talking about, the WHO Hearts program, but evolve and modify and adapt that as much as possible to the CKM.
Yeah, and I heard just some important themes. Team, trust.
Absolutely.
Most important theme.
I couldn't agree more.
And then community, because we can't design solutions that we give to communities. The communities need to be engaged, involved, empowered in those solutions. And then we often, talking about silos, I mean, so far we've touched on NCDs, but you mentioned many countries still as priorities infectious diseases. Not surprisingly, infectious diseases and chronic diseases are interconnected as well, bidirectionally. And so maybe some of the models that have been developed for infectious diseases can be connected to models we've developed now to think about related to chronic diseases.
So on that, if I can just mention one more thing, is that in Tanzania, we are working with the HIV infrastructure and integrating our community-based model with the infectious disease, so and co-creating. So I completely concur with with your comments here, that co-creation, community participatory approaches to develop those models and empowering the community. And a lot of times when we work, the solutions come from within the community. We just have to share and involve them, and co-creation is the
Right, and we're definitely going to touch on technology, AI, digital health. I mean, is that going to be the solution or a solution? But let's step back for a second for Professor Sitar. Is whatever we're going to call this interconnectedness, we can add many letters from the alphabet. How important is obesity to not only our understanding, but to the solutions, and how do we think about it? Because this is a life course challenge, and if we wait until the life is, midway through, I mean, we can greatly improve quality of life and outcomes, but how do we think about this, broadly within our populations, even from pre-birth to looking forward?
So Larry, that's it's a great point. I guess trying to tie a couple of themes together. Number one, all of the things that Tazeen, you just described is really important. We can improve how we help people navigate through the world in terms of improving their lifestyle. We can do that. But we're up against the fuel of excess calories everywhere and sedentary lifestyle. So it can only ever be sticking plaster. We can make differences in individual lives. Some people do really, really well. But if you look at the levels of obesity in high-income countries, who are the most people living with the most obesity? It's the poorest. And it's getting worse. And it's getting worse at a rapid rate. In middle-income countries, the gradients is now equal. But 50 years ago, it used to be the richest. So it's changing. In low-income countries, it's the opposite. It's the most affluent are the most overweight at the moment, but it's going to change. Mm-hmm. And other thing I would say to you, Larry, is our genes haven't changed in the last 50 years. Yeah. Nothing has changed. The only thing that's changed is the environment. Yeah. So if we don't sort the environment, whatever we do, we can do a lot, and we have to help people. We can't not help people, But unless we change the environment in a meaningful way, and do you know which groups are going up in terms of obesity the fastest? And you mentioned this in your mention. It's not the elderly, it's not middle-aged, it's young people. And why? Because young people are being born in an environment now which is much more obesogenic than you and I were born in. So they're up against it in a much greater way than from the start. So it's a freaking mess. I hate to say it.
Yeah.
And unless we sort the environment,
Yeah.
we can only ever do partial recovery,
Yeah.
which is what you said.
Yeah, and so, we can use that in quotes. It's a freaking mess.
Yeah, excuse me, sorry, it's my
no,
Glaswegian.
No, I think that's a very appropriate way to discuss where we are today, and how do we begin to dig out. And here I'm going to hand it back to Dr. Rosande about, we've talked about health systems some. All of us, let's think about, the role of health systems, public health, and public policy, because without that engagement of involvement and support, we will continue to have this vicious spiral impacting those across the world.
Sure. I think CKM or anyone, anything, is this interconnected, this cluster of risk factor probably is the most neglected conditions today, neglected by society, but general population, but also neglected by healthcare teams and neglected by governments. Nobody are seeing the real impact and the opportunities to implement a public health approach capable to address these conditions. I fully agree with my colleague on the importance of incorporating team-based care approach, because the burden of hypertension, diabetes, chronic kidney disease, and obesity is overwhelming. Physicians cannot resolve this pandemic. We need to incorporate smarter approaches based on, for example, non-physicians, healthcare workers. In heart, particularly, we work on this, and we publish on February Heart Team-Based Care, which is the next generation of instruments of hearts in the Americas. So now we are in the process called Heart 2.0. So Heart 2.0 is a global initiative, a collaborative initiative to incorporate the CKM approach into our clinical pathway. Our clinical pathway currently has not just a treatment protocol for hypertension, but also incorporates statins, aspirin, and even a vaccine chart, recognizing the vaccination rates in adult populations are extremely low, and communicable and non-communicable infectious disease are closely interconnected as well, and vaccines can avert many fatal and non-fatal cardiovascular events. So we try to incorporate this integrated approach. Recently, last month, we published a paper in American Journal of Hypertension, leading by Dr. Pedro Ordóñez, who is the technical leader for hearts in the Americas. This paper contains our vision on the importance of defining the role of each instrument, clinical guidelines, treatment protocols, and clinical pathway. Clinical guidelines are absolutely necessary to analyze and synthesize the overwhelming burden of scientific information, but they fail in implement these recommendations in the clinical practice. So for that reason, instruments like roadmaps from WHF or protocols, or even better, an integrated clinical pathway which contains recommendations, evidence-based recommendations from different guidelines, from hypertension, from diabetes, from vaccinations, into a simple, and simple doesn't mean simplistic. Clinical pathway is simple, and primary healthcare teams love it, but it doesn't. It is not simple. It's not simplistic. It is simple, and it's very important to keep it simple to effectively implement the evidence into practice.
Yeah, I like that distinction, simplification. And then you just talked about integration. Our protocols, our guidelines should be integrated. You know, here at ESC, there were 5 guidelines released. You know, we tend to, as people who get excited about guidelines, you know, we listen, we're excited. Often the guideline document is 120 or 140 pages. And, you know, the excitement for the session for the lipid guideline, it was standing room only. People couldn't get into the room. So, you know, at the launch, there's excitement. But then if we don't implement the guidelines, you know, we'd say sit on the shelves. So I think,
Larry, can I say something?
Yeah, please do.
And you're completely right. I mean, the other thing is when you get lipidologists to make a guideline, they only think about lipids. They don't think holistically.
No.
And that's the problem. And so that they hammer home, you have to use this treatment and this treatment and this treatment to get the LDL to. Wait a second. There's so many other treatments out there. Why don't we have one unified guideline nowadays that actually, and why don't we all work towards that? Because they then become disenfranchised, but what? Stuff it. You know, who cares anymore? We have to actually move towards holistic care. How are we going to do that? We've got to get away from old fiefdoms and egos. We've just got to move together and do holistic guidelines.
But can you imagine a primary healthcare physician has to rate maybe or choose which one read among 10 guidelines just for address one risk factor?
I know, it's crazy.
But a primary healthcare physician has to face many conditions, not just hypertension or not just chronic kidney disease, but also infectious disease and mental disorders. And we need to develop practical instruments with the most important and effective recommendations included there.
And that's where I think maybe you're going to come to that, I think AI is going to help. And that's where the partnership of AI with the physicians is really going to, I think people are scared of AI, but I think people shouldn't be scared of AI. They should really embrace it and say, how is it going to enhance our practice and patients, and how they're going to prevent patients from slipping, you know, through the gaps. So that's...
And I'm glad you already took a step into the direction of AI technology, because, you know, this is moving very rapidly. At the same time, this knowledge is moving rapidly, our technology is moving rapidly, our science, our pharmacotherapies, you know, so on paper, we're getting more and more sophisticated to find the solutions. But let's come back to the primary care community itself, to the people living with multiple long-term conditions, CKM and beyond. You know, and is AI or technology going to be a solution? Can we afford it, number one, especially in low and middle income countries? And then, you know, whenever there's discussion about AI, I bring it back to HI, human intelligence.
Yes.
Because,
Yes.
you know, we can't just leave it be to AI. So I'm going to go down the line with each of our panelists here. Maybe if you want to start, and keep your answers somewhat brief, because I do want to be sure we have time at the end of the Heart Cafe for some questions and comments from the audience. and also to finish on time so you all can move on to other exciting things here at the Congress. So AI, is that the solution or part of the solution, or you're skeptical?
Yeah, I think this technology is evolving so fast, but I think it could be very useful to support the decision of the health teams. But we think the most important is to address this problem from the public health perspective, from a programmatic perspective. We have to think the approach of cardiovascular prevention like an immunization program. It should be massive, it should be simple, and it should be based in non-physicians workers, nurses, pharmacists. We must leverage in all these people. I always talk about the research from Professor He, published on Lancet a couple of years ago, and implementing a strategy pretty similar to Heart's initiative. They achieve an impressive result, not just in hypertension control, but also in preventing cardiovascular disease and a decrease in around 15% in global mortality. So, like Nike says, just do it, because we have the evidence, we have the instrument, and we need to implement them.
For our other panelists, as you're thinking about your answers, we talked a lot about health being local, differences across the world, and then we talked about the team and trust. So as we think about technology and AI and the engagement of those living with, is how do we make this a trusted incorporation of AI and technology into part of the solution?
Yeah, I mean, I think that the human factor is going to be key in here. I think AI without the human factor in a lot of places in the world is going to be a no-go, quite honestly. I think that, and it's going to, the scale up is not going to be as quick as we think that it's a success of the scale up. I think it's going to take time. As you've rightly said, it's going to require a lot of community engagement and a lot of training, a lot of hands-on training, even in places like Singapore, where you would expect that people are very tech savvy. We have a lot of people on ground who are training. I think that element, the patients, the providers, I think it's going to take a lot of resources that way. And even after you have that, there's a technology fatigue that comes in very quickly. So you'll have to address a lot of those things, and you have to see the long-term success, not just the short-term. So I think those factors but I think it's a move in the right direction with a human factor. It facilitates a physician or a provider or a team-based care management approach, but not alone by itself, by any factor. So
great. Professor Tar.
Yeah, no, I completely agree. The human factor, I think we actually need to train more clinicians who understand more than just their own single speciality. That's just a no-go anymore. Cardiologists need to understand obesity and diabetes. Diabetologists need to understand kidney disease. It's just crazy. But AI can definitely help. I think it can help because obviously we've got lots of new classes of disease-modifying drugs. There's a little bit of complexity. Training multidisciplinary clinicians, but having AI say, well, actually, for this patient, based on these risk factors and these prevalent diseases and his future trajectory, his best two treatments are X and Y. He's going to have them. And in addition to that, if he takes X and Y, and we can also help him improve his lifestyle in the following ways by capturing AI or biological feedbacks, although there is a bit of, I don't know. But, that would be great. Do you know what would be brilliant? So I think AI definitely does have a role. And if we can put that into primary care, because that will then help primary care provide the confidence that, actually, yes, for this patient, it's the SGLT2 inhibitor was going to give him the maximum benefit. For the other patient, oh no, metformin's enough. He's not going to get kidney. So those are the kind of ways I think we need to think. The other way I would love AI to work, this is completely balmy now, I wonder if it can help, you're going to laugh, help governments work out how do we change the food environment but not destroy the economy? How do we do that?
Yeah.
Because, can we change the food environment in a way that still keeps companies profitable, but actually improve the economy in other ways? Because that's why economies are not doing this.
Sure.
No government is tackling the food industry because it's a big part of their economy. And that's the big
That's
problem.
huge.
Yeah, and I was going to ask that, AI technology, can it help our, public health challenges? And you said,
Possibly it could.
possibly. So we're going to go down the line, starting with Dr. Sattar. One sentence. I know this is complicated. This is complex. It's one of the reasons, there's not one solution, but if you could pick one area of focus or one of the concepts we've talked about during this Heart Cafe, what would be, the World Health Organization has a concept of best buys. So what's your best buy?
My best buy is actually any advocacy that we can do to help change the food environment and policy. Everything else pales into, I'm not going to say insignificance because everything matters, everything we do matters, but it's the big ticket. Cardiovascular disease is not separated from obesity. Lots of young kids, obesity early on, more diabetes, more premature cardiovascular disease, more heart failure, more kidney disease. So if we don't solve the food environment, the sedentary environments, and try and change, and we're looking down the barrel.
Professor Jafar?
I would say that no more single disease focus now, from now on. Everything that you have, every guideline should be thinking about multimorbidity, and especially the cardiovascular, kidney, metabolic. And so, the diet and food environment needs to be complement that.
And Dr. Razande?
Yeah, I think this cluster of interconnected conditions, first of all, its prevalence and burden is out of control, and it's being neglected by different actors in society, people, health teams, governments. So we need to raise our voices, advocate for put this topic in the center of the stage and push governments to take actions in the right direction, because we are in a burning platform, and we have to recognize it.
So we talked about interconnectedness. Thanks to all of you for attending this Heart Cafe, and hopefully the connections we're making, the listenings, the learnings. What I'd like to do now is open up to the attendees here for comments, for questions, or maybe some of your solutions that we haven't discussed as our expert panel here. We want to hear from all of you and how we together can begin to address through actions and meaningful impact. Are there questions or comments? Please, and there should be a mic. Here it comes. There's the mic.
Thank you very much. I'm Frank.
Introduce yourself, yes.
Yes, I'm Frank. Frank Ziza from Burundi, medical doctor, public health specialist. My first question is to I think Dr. Jafar. Yes, I'd like to get maybe your advice or your take on, what we can do maybe in low and middle income countries we are doing things, but we want to, your perspective, with your experience you describe in Bangladesh, for example. In Burundi, we have like 10 cardiologists for 12 million people, and most of them are in the capital city. So now what we are trying to do is just to implement what we call community health kiosk, where we can screen people and leverage technology of digital health and refer those people use like e-prescription, those kind of things, to leverage technology. So is it something that you have had some successes or some good feedback? So because it's something that we are starting, so we want to know your perspective. Thank you very much.
Yeah, great. I think that's a great question. I know that there have been some other models of care where they've evaluated public health kiosks. I think so long as you have a system of care where there is a standardized system, you have a sort of a team-based care approach where the kiosk is connected to a health system, is a standardized system that can perhaps be, you know, and it's evaluated, then I think there is, you know, that those can be a model that can perhaps work in the system. I don't know that, you know, if so long as there's a good referral system and there's a primary care person who's at least seeing the lower risk patients. So I think you just need to have a standardized mechanism of, you know, connected to the primary healthcare system, then a district healthcare system, so a standardized system.
Are there other comments or questions from the audience? Just, oh, go ahead, please.
If nobody else has a comment, because we've sponsored the session, so
Yeah.
my name's Lucas, I'm from Bayer, and I mean, first I just want to thank you all. I feel like I could have a hours-long conversation with each of you on each of these topics. Time's too short. But actually what I wanted to ask about is one thing that you haven't touched on yet, and I think it fits well with the theme of interconnectedness, and you know, I think we're staring down the barrel of not only, you know, this particular incredibly important issue. I'm deeply concerned about it. And on top, we also have climate. And, you know, the impact of heat, particularly, not only on our food chains and our food supply, maybe there will be a forced reset of our food supply soon. But anyway, do we need to be incorporating this as well into our thinking, especially concerning kidney disease, especially in Southeast Asia, where there's hundreds of millions of smallholder farmers exposed to extraordinarily difficult conditions?
Yeah, when I introduced the session, I talked about that this entity is one of the greatest threats to humankind on this planet. Climate change, our global health. When we really think of global health, we often talk about the people on the planet. Our youngest son is trained in environmental science and business and environmental engineering, and he reminds me when the people are gone from the planet will possibly recover. And we actually saw this during the pandemic. You know, we talked about this interconnectedness. We really didn't mention the COVID pandemic, and it's almost like it didn't happen, you know, when it really was catastrophic. I'm glad you touched on vaccinations as part of the interconnected solutions. Particle pollution, let's just take that. In India, I believe particle pollution is now a greater contributor to cardiovascular events than smoking. Extreme heat, but also extreme cold. And then just like health is local, our planetary climate challenges are also local, even within a sphere of miles or kilometers. There are populations living in very different climate-based ecosystems, shall we say, and their risk is very different. So I'm glad you brought that up. But now talking about the complexities, I mean, and we won't go back to the AI question, but is AI gonna personalize medicine, help the primary care clinicians, help, you know, the communities, and help us with, climate change. So would like to hear from our other panelists.
Yeah, I mean, I agree with, first the AKI, the acute kidney injuries that one gets because of the heat, especially in the farming communities, and the unprecedented heat that we are seeing, and of course, and kidney features centrally in the CKM, and not just in the prevent equation itself, but also for the first time it has been neglected, but now, and there's this very strong link with the decline in GFR with the with cardiovascular morbidity mortality. So that's central role. But also flooding, the geographical issues, the huge flooding that happened right after that, and the unprecedented types of flooding that we are now seeing everywhere, literally. So I think, and what that does to health systems and supplies of medication and other access to health services. So there are so many factors and ways that which unfortunately, and we are, now testing drones supplying medications to, to areas that are, and also patients with cardiac arrest, how do they get to the hospitals when in such situations. So these are very, very challenging and types of situations that are created because of the climate change that will need to be addressed.
Yeah, and I want to add a comment because, of course, climate change is a challenge, but regarding chronic kidney disease in some rural communities, it's also related to the use of toxic chemical substance without any protection. So this population are exposed to the traditional risk factor and additional risk factors related to their lived conditions.
Oh, go ahead, please.
No, I don't have anything clever, Lucas, to say about climate change. Worries the hell out of me. I mean, for all the reasons. Whether it will lead to a change in the food environment in a positive direction, I don't think so. So if you've got any power at the governmental levels, I think you need to go and speak to various leaders of countries and try and convince them about this. Otherwise, it's all going to, actually, I don't see anything other than things are going to get worse. We're going to be having to shift communities into areas which are not affected by climate change. Some places are going to get too hot, some places are going to get too wet. It's just going to be, I'm going to say a freaking disaster again. But, that's what it is. Let's not beat about the bush.
Yeah, and this, you mentioned, I mean, here we are, same genes, our environment, how dramatically it has changed. We know that microplastics are in all of us and affecting, inflammation and vascular risk. And so there are many layers of this interconnectedness, both as we think about solutions. There are many layers of interconnectedness as we think about the challenges. On the one hand, it seems daunting, doesn't it? Like we can't overcome this.
But we mustn't give up. We have, there's a lot we can do, as we've heard. There's a lot the guys are doing. We can do a lot of things better. The plus side is there are some therapies that are coming forward that can help us perhaps combat some aspects of the environment, the kind of food noise aspects. But of course, they're injectable, they're expensive, they're not necessarily scalable. And we need more of those trials with particularly orals in low and middle income countries, and the industry needs to invest there. Maybe they can help us reverse engineer the environment so people eat less. That affects the climate in a positive way. I don't know. That's the only hope I can see, actually.
Yeah.
But I would just one thing that I would say, in the Life Essential 8, advice that comes out, healthy lifestyle. In the CKM, your CKM stays 0, which is, you're healthy, there's nothing wrong with you, which is great. If one really focuses on that, you're staying healthy, despite the environment may not be the best for you, but whatever you can do of all those elements, your sleep, maintaining weight, keeping your blood pressure under control, but trying and emphasizing that, and not progressing on to the next stage. I think that's really key. Yes, we've got brilliant therapies out there, but putting on those therapies will not bring your risk down to the same level as you were when you were stage CKM 0. So let's try and stay on that stage, and getting that message out, I think, is also very, very important.
Yeah.
So prevention.
But it's clearly, we're not any greedier than previous nations. You know, it's the environment, and some people are very susceptible because of the genes and their life circumstances.
Yes.
And that's the big issue, you know.
That is a huge, the social determinants are a huge issue, and I think for that,
Some
very
genetic.
strong and genetic and very strong advocacy is needed, very strong advocacy.
Well, we're going to wrap up. I want to thank our esteemed panelists, our passionate, purposeful, and actionable panelists for being here, first of all, for their advice, for their wisdom. I want to thank World Heart Federation for hosting this Heart Cafe. This is such a critical area. As I mentioned, World Heart Federation is in the midst of a roadmap, and we, the roadmap team, look forward to, I'm listening, by the way, to all of these comments and realizing, you know, there's some things we need to go back and put into the roadmap. And we want to thank Bayer again for their sponsorship. We're going to wrap, and thanks to all of you for making time out of your busy time in the Congress here for joining us. We're going to wrap up. Have a great, wonderful rest of your day and rest of the Congress here in Madrid.
Thank you.